arguably more commonly thought of when talking about transfusions or talking about transplants would be solid organ transplants. That's kind of what everybody goes to when they think about a transplant, and probably not about a blood transfusion. So this part, we'll talk about solid organ transplants, and then we'll look at bone marrow transplants at the end. So with a solid organ transplant, it's pretty routine. Organ transplantation is something that happens very often, and it saves many, many, many lives. Thousands each year of human lives are saved because of organ transplantation. Most of them are going to be transplanted across some sort of tissue typing. With the transfusions we saw, it was ABO, blood group typing, but with with organ transplants, we're looking at a more strict set of tissue typing that is done, and likely ABO blood matching is done as well. And the types of tissue markers that are being tested for compatibility are going to be those HLA antigens or MHC molecules. Same thing, but they're HLA class 1 and 2 genes make these antigens that are going to be used for tissue typing. In the situation of a transplant recipient, they have a naive T cell population that will include clones of reactive T cells against non-self. And these non-self T cells will recognize, or could potentially recognize, any HLA molecule that isn't their own. That's what that's what the immune system is looking for when they're seeing non-self. And so CD8 positive T cells will respond to non-self HLA class 1. CD4 positive T cells will respond to MHC or HLA class 2 differences. So therefore, the alloreactive T cell response can produce effector T cells that are both CD4 and CD8. So both can actually have an attack on the organ. It can be a cell-mediated attack through the CD8 positive T cells, or a humoral antibody attack through T helper cells producing antibodies to attack those organs, which can lead to an acute rejection. And we can see this somewhat like a type 4 hypersensitivity. Organ rejection can also involve blood groups, because if we think about an organ, especially like a kidney, they're highly vascular. They have a lot of blood vessels running through the cell or through the tissue. And endothelial vessels, even if all the blood is drained out, those endothelial cells will present ABO blood groups as well. So if a type O individual receives a kidney transplant that comes from an individual that is type A, then their anti-A antibody will quickly destroy that tissue by ripping up the blood vessels because of that A antigen present. And when that happens, that can then kill the organ because there's not going to be a blood supply to it. And of that organ, which we call it a hyperacute rejection. So complement is being fixed because there is antibody binding to the surface of the graft, and complement will destroy the cells in that graft in rather quick fashion. There's also the potential that organs are rejected, but on a much slower pace. And we would call this a chronic rejection. So this can happen months or even years after an organ has been transplanted. Typically, this is going to look something like thickening of the vessels within the vasculature of the organ itself, and that will cause narrowing as those vessels get thicker and thicker, the lumen of them gets smaller and smaller, allowing less blood flow to be occurring through there. When blood supply drops, then the graft is eventually going to become, there's going to be an insufficient amount of oxygen delivered to those cells. That can lead to ischemia, and then that can lead to cell death, which of that graft, and eventually death of the graft. And again, this can take a little bit longer, and we call this a chronic rejection. So we can have a fast attack on the graft called an acute. We can have a hyperacute where blood ABO groups don't match, and it can be very fast and destructive, or a longer situation where we have a chronic rejection. But in any of these cases, it's pretty important that two complementary tactics must be done in order to increase the chance of that graft surviving. First of all, picking a graft that is going to be pretty compatible with the recipient is number one priority. After that graft has been put into the recipient, the second approach is to prevent the recipient from mounting an immune response by using drugs that interfere with T cell activation. These then are classified as immunosuppressive drugs. There's a variety of different types, and they're going to affect T cell activation at different points along the activation pathway. Typically, this is going to be done, it could be started prior to the transplantation. And so the patient will begin a course of drugs that will probably just wipe out a lot of the lymphocytes. This leaves the patient vulnerable to infection because they're not going to have those immune cells present to fight any other type of non-self or any other type of threat. And so they do have a weakened immune system. And then during the transplant, and then years, and sometimes it's a lifetime after the transplant, there needs to still be a low level of immune suppression to prevent graft rejection. In different areas or time points or ways that T cell activation can be prevented. And we can get there if we think back to how T cells are activated and what ways we can prevent that. Number one, we can stop the T cell recognition of antigen, which would be MHC1 or MHC2. That's part one. Or we know that a naive T cell won't be fully stimulated unless it gets that co-stimulatory molecule generated when B7 binds CD28. Third kind of ramping up signal that we touched on, we didn't talk as much in length about as the other two, but of IL-2. IL-2 receptor, when a T cell is not being activated, is in a form that doesn't accept IL-2. But once a T cell gets its first and then second co-stimulatory signals, then IL-2 is produced, the IL-2 receptor forms fully, and then IL-2 will come back and act on itself in autocrine fashion. So that can also be prevented to prevent or at least help reduce naive T cell activation against the graft. Here's an image that just shows those three different spots. First of all, this is our number one signal that can get T cells going, so we could block that. Any type of monoclonal antibody that blocks CD3 so that there's no signal, so it kind of just stops that signal. Second one is our binding of CD28 to B7. We can prevent that with some sort of protein or monoclonal antibody that can stop that signal. so there's no co-stimulatory molecule, or the signal 3 is IL-2 binding. There is a monoclonal antibody that can prevent this binding, which would stop this signal. And then along the way, there's other types of drugs that can interfere with different places of T cell activation. So a lot of different drugs that have been utilized. The ones I'm most familiar with would be like cyclosporin and tacrolimus. They're going to prevent IL-2 transcription. And so IL-2 isn't made, so essentially it's blocking this third signal. We can, those are probably the two. Methotrexate is another one that I have heard of, but again, there's a lot of different types out there, and probably new ones made even since the publishing of this text. The point is that immunosuppression is a tactic needed along with finding a histocompatible donor. Okay, but here's the downside, right? Any drug that is sufficiently powerful to inhibit alloreactions of a graft also is going to inhibit T cell activation across the board. And so normal immune responses are also going to be lessened, even if it is a threatening pathogen. So consequently, administration of these drugs, which is going to be mostly high levels right after the graft, and then continues throughout life, maybe decreasing over time, the individual that is the recipient is going to be, pretty immunosuppressed, at least initially, and then less, as the drug decreases. So as their systems accommodate the graft, then those drugs can be lessened, maybe stopped at some point. But point is that immunosuppression is not going to be specifically just for the graft. It's going to be across the board. And so side effects can emerge when people take immunosuppressive drugs for a long time, especially if we're looking at cell-mediated suppression. Cancers are often cleared or removed from the body by CD8 positive T cells recognizing altered self. And if CD8 positive T cells are decreased, then we can see more malignancies come about when people are on long-term immunosuppressive drugs. But still, the grafting or the transplantation saves many, many lives, and so it's still done. But there's so many people on the waiting list. So this is actually a little bit dated from some statistics from 2020, where we see the number of organs needed and then the number of organs that have been received. Liver, heart, lung, they're pretty close. To where where there's an even heart looks like there were more received than could actually be donated. But kidneys, there's definitely a long waiting list for kidneys. And so the number of patients who could benefit from these transplants actually is higher than those that actually can have transplants done. So the waiting list is long, especially like you see with kidneys. And so this is kind of like my little plug to say, hey, be a donor, make sure your family knows your wishes and be a donor. Okay. The cornea of the eye was actually the very first solid organ transplant to be successfully done. And it is the most common solid organ transplant that is done today. And there's more than 30,000 corneas transplanted, and these corneas come from cadavers. So 30,000 a year, so that's pretty crazy. But the eye is another area of the body where inflammation can be pretty harmful. And with inflammation, it can lead to scarring of the tissue, which can then lead to blindness, right? And so because the inflammatory environment can cause so much damage, the eye environment is by nature in a non-inflammatory environment. And so there is definitely a push towards making T regulatory cells and secreting cytokines like IL-4, TGF-beta, those anti-inflammatory cytokines. And because of that, cornea transplants are tolerated pretty well. There's not a lot of rejection of them because the eye is an anti-inflammatory environment by nature. Another similar organ that's transplanted often and with high success is a liver transplant. And this is because liver cells actually express a much lower amount of HLA class 1 and 2 molecules. And so when a liver transplant is done, yes, tissue typing can be done. The matching doesn't have to be as strict, but ABO is really the big thing that is being matched when looking at a liver transplant. And because, because of this, liver transplants are really pretty good. They're not rejected as often as, say, other organs. So liver cells, again, are going to be, bombarded with garbage all day long. And so it's just not a big immune focus of the body, because it's like, the liver is garbage dump. It's going to clean everything out. And so not a huge inflammatory environment as well. So cornea and liver transplants are done with pretty high success rates because of the anti-inflammatory nature of these areas. Okay, our last type of graft is going to be a bone marrow transplant. And so this is just kind of flipping everything around the other direction. And when we talk about the recipient and the host, in a bone marrow transplant, the recipient, the donor and the recipient, not host, the donor, the recipient is getting the donor's immune system. Sorry for that whole mess there. So because the bone marrow transplant is giving the entire immune system to the recipient. And then that immune system has to work in the recipient's body, even though it is somebody else's immune system. So let's look at that. So a bone marrow transplant or hematopoietic stem cell transplant is used to reconstitute a healthy immune system for individuals, usually children, that have an immunodeficiency. It is also going to be a treatment of choice for people with, like adults with leukemias. So blood cancers are going to usually be cured with a bone marrow transplant. In a hematopoietic stem cell transplant or in a bone marrow transplant, those hematopoietic stem cells, those pluripotent that can become any type of cell, any type of blood cell, are given in a transplant, given through IV. And it's done after the recipient has had their bone marrow completely obliterated, completely destroyed by chemotherapy, to the point where they have no immune system at all, and they're highly, highly susceptible to any type of infection. The hematopoietic stem cells go in, they reconstitute the bone marrow, they slowly build up a new immune response or a new immune system, and then the recipient has a new, brand new immune system from the donor. The patient receiving the bone marrow transplant first has to have the immune system, their current immune system, completely annihilated, completely removed. And so we call this myeloablative therapy. The entire bone marrow is wiped out with chemotherapeutic drugs. And by doing this, it's going to serve two purposes. Number one, it's going to completely remove the chance that the recipient's immune system will attack the graft. You totally take out the entire immune system, there's not going to be any immunity to fight off the graft. And number two, it's going to open up space in the bone marrow stroma for the recipient cells to take up, the donor cells to take up. So the donor cells can get into the bone marrow and have all this space to start to replicate and reconstitute the recipient. After an individual has received hematopoietic stem cells, those stem cells will proliferate, go through the process of hematopoiesis, make all new red blood cells, make all new white blood cells, make platelets, and everything that, and bone marrow, stromal cells. After 2 or 3 weeks, then the individual will start to have an immune system based on their donor's cells. And with time, they will have a fully reconstituted immune system and won't be in an immunosuppressed situation any longer. When that immune system has been fully reconstituted, the patient, though, the recipient, is known as a chimera because they have hematopoietic cells that are of donor origin, but all the rest of the cells of the body have the genetic profile of the recipient. And so we have this weird situation then where the new T cells have to recognize MHC on the recipient's self cells. So we have the recipient's antigen presenting cells with the original genetic profile, but yet we have a whole brand new set of T cells with the donor's genetic profile. And so that positive selection where we're making sure T cells are able to recognize self-MHC, it's not really self-MHC anymore, it's recipient MHC. And that's why the strictest of all strictness of HLA matching has to be done to get the most overlap as possible for the recipient to not be destroyed by the new donor T cells. So the recipient and the donor must have HLA-1 and 2 allotypes in common. The more, the better. And that's kind of what this picture is showing. If we have a situation where the HLA typing isn't as great as it should be, rejection can happen, but it looks different than what we saw with an organ rejection. In this case, the donor T cells are going to recognize the recipient's cells as being non-self. And the graft, which is the bone marrow, is going to attack the host or the recipient. And so we call this graft versus host disease. And so the main cause of damaging alloreactions is a mature donor-derived CD4 and CD8 T cells in the transplant that will attack the recipient. And so we call that graft versus host. This can look like a type 4 hypersensitivity because we see this presented as involving the skin. You get a rash, intestines. There can be a lot of diarrhea or other types of inflammation in the intestines and around the liver. So graft versus host disease looks very different than what we see in organ transplant, solid organ transplant. So these mature T cells from the donor attack the recipient. Now, despite the large number of registered donors, patients who are eligible for hematopoietic stem cell transplants have a difficult time finding HLA matched donors. And so to help these patients, there are a few different ways to do autologous donations, where there is using self bone marrow stem cells to reconstitute. So patients' stem cells can be collected at different points of time. First, at birth, there can be umbilical cord stem cells saved. And then they get frozen down and they can be utilized if ever needed. Another way is that there are some stem cells that get out of the bone marrow and into peripheral circulation, and that can be encouraged through different drugs that can recruit more stem cells into peripheral circulation, and then they can be pulled out and isolated. Now, this type of situation, they're not as, sometimes can't be as useful. So take, for example, the umbilical cord. If there's already a genetic issue leading to a immunodeficiency, that genetic issue is also going to be present at birth. So that might not always be the best. And then with recruiting stem cells from peripheral circulation, if the genetics have changed, potentially you won't have the same, issues arise, but this isn't always the greatest. I'm trying to think of like, you can do like a multiple myeloma where you can do this type of transplant for people with multiple myeloma, and eventually it ends up coming back. So it can prolong life, but it might not be a permanent solution. Either way, because autologous transplants are perfectly histocompatible, the patients don't run the risk of graft versus host disease. So they're not giving immunosuppressive drugs, but relapse is significantly higher than if they were to get a donor that does not have the same genetics. So, okay, so we made it through that chapter, and yeah, you guys just, let me know if you have questions, and we can talk about this in class if you're in my class. Otherwise, you can message me.